Hi, everyone. Thank you so much for joining us today to celebrate a little over 2 months until Medicaid expansion takes effect in Oklahoma. My name is Emma Morris, and I'm the Healthcare and Revenue Policy Analyst at the Oklahoma Policy Institute. It has been a really long road getting to this point, and a ton of people have been working on Medicaid expansion in Oklahoma for years. We are so thankful for the hard work that so many advocates and policymakers have done to get us here. As Oklahoma gets ready to implement Medicaid expansion, we are expecting some 200,000 working-age Oklahomans to become newly eligible for health coverage, which will have ripple effects throughout our communities as these individuals are better able to work and to parent. It will strengthen our hospitals and other healthcare providers as they see fewer uninsured patients, and it will bring increased jobs, tax revenue, and state savings for Oklahoma. We are counting down the days until Medicaid expansion becomes reality on July 1st, and you can follow along and get involved at okpolicy.org/countdown. One area that doesn't always get as much attention as it should when we talk about healthcare policy is American Indian healthcare systems. We are really excited that today we get to hear from experts in this area. They'll discuss the current state of affairs and how things may change as the state implements Medicaid expansion, as well as how Oklahoma can act now to help ensure that expansion is successful. If you have any questions throughout the event, please put them in the chat box wherever you're watching, and we will have time for those at the end. So before I turn it over to our speakers, we're going to hear from Ginger and Heather, who are part of a family who rely on both the Indian Health Service and Medicaid to access health care.
My name is Ginger Glory, and I am a registered nurse, but first and foremost, I am, the wife, the mother, and the grandmother of 9 grandchildren. Medicaid has made a difference in my family's lives. It means that we can focus on being a family. We can focus on important things together and not have to make some of those hard decisions of, how we're going to pay a bill or what have you.
My name is Heather Bridges, and I am a registered nurse, and Medicaid is important to me because everyone deserves, the best healthcare.
Absolutely.
They do have chronic conditions, stuff that they have to go every 6 months for like their heart conditions, and I think that just having that available to them and knowing that they can go and they can get preventative care and follow-up appointments and make sure that everything is still okay and we don't need to do any further treatment, that means a ton, because if something were to be bad or change in their status, then we can address that and we don't have to decide, okay, how are we going to pay for this next visit, or how is my daughter going to pay for it? But, the passage of State Question 802 means that that gives so many Oklahomans an opportunity. It gives them the opportunity to get screenings and, mental health care, which is something that we completely overlook all the time. And that creates other, chronic issues. So, I think that it means that they're taken care of as well. Like they have an opportunity to do just basic checkups, make sure that everything's still okay and that, their health is still in good standing. And if it's not, then they can address that at that time and it not be a hit to their pocketbook or, a bill that they don't get to pay. I want everyone to go and have that opportunity. I don't want them to be faced with a hard decision and something that could have been easily prevented most of the time.
Yeah. Change starts with us, and we have a responsibility as human beings to care for one another. And change, when I'm saying change in policy, change in how we live. And, now that this is passed, I think that we should be responsible and we should be good stewards. And that now that people, a lot of the uninsured that will be eligible to utilize the expansion, they need to do it. They need to get involved. They need to get involved in their own health care, make wise decisions, be good stewards. And then we need to support that, as just one another, one person to another, and value and respect one another. And so why do I say that? because we need to encourage our brothers, our sisters, our family members to go get checked out. Go ahead and apply. Even if they think that they're not eligible, they need to apply to see if they are.
Sometimes it's easy to forget the immense impact that Medicaid can have on our friends, our neighbors, our family members, the people around us. And I always love hearing real life stories about that impact. So thank you, Ginger and Heather, for sharing your stories. So now for our speakers, we will first hear from Kasie Nichols, who has served as the director of the Citizen Potawatomi Nation's Office of Self-Governance since 2017. She also serves on the Self-Governance Advisory Committees for both the Bureau of Indian Affairs and the Indian Health Services System. She has a bachelor's degree from Southeastern Oklahoma State and a master's degree in microbiology and immunology from the University of Oklahoma. We're also going to hear from Robyn Sunday Allen. Robyn is a tribal citizen of the Cherokee Nation, and she serves as the Chief Executive Officer of the Oklahoma City Indian Clinic, a position she's held since 2009. Robyn has a bachelor's degree in psychology, a bachelor's degree in nursing, and a master's in public health, all from the University of Oklahoma. And last, we'll hear from Yvonne Myers, who's a tireless advocate for access to care with over 40 years of public health and policy experience. While at the State Department of Health, she was the agency liaison to the OHCA and now is a consultant for the Citizen Potawatomi Nation Health Services, with a focus on the Affordable Care Act, Medicaid, and Medicare. Yvonne is extremely grateful and proud of the opportunity to work with the outstanding Indian Health Service, tribal and urban Indian clinic leadership and policy staff in Oklahoma and on the national level. So now I will stop talking and I will turn it over to our speakers, beginning with Kasie.
Okay, thank you so much. First, want to say hi, everyone, and thanks to Oklahoma Policy Institute for such a great opportunity to discuss the importance of Medicaid expansion and as it specifically relates to American Indian healthcare. We're just really grateful for this opportunity. Okay, you can go to the first slide, please. Okay, so we thought that it would be important to set the framework for this discussion. So if you've heard that healthcare for our American Indians, Alaska Natives is a trust responsibility, here's what that means. Tribes are not simply a group of people, but instead they are dependent sovereign governments. So interactions between tribes and the federal government were explicitly governed by the first article in the Constitution. So that's where it's addressed early on in our nationhood. Then as the U.S. expanded, treaty after treaty after treaty was signed. And it's important to kind of take a step back and recognize the fact that treaties are nation-to-nation agreements. Just like treaties signed with foreign countries, tribal nations made contractual and binding agreements with the United States where they ceded their land for the government's promise that certain services would be provided to their people, like healthcare. Tribal members today know that their ancestors sacrificed their lives and their land for this promise. So it's not just some social welfare program, nor is it insurance. Tribal healthcare was paid for centuries ago, and the federal trust responsibility is actually a legal obligation. So this unique legal obligation is reaffirmed by all branches of the federal government, even today. And in fact, Congress declares this legal obligation in several statutes. So next slide, please. Okay, so one important Indian healthcare statute is the Indian Healthcare Improvement Act, where Congress explicitly states that the nation's policy is to fulfill its special trust responsibilities and legal obligations to Indians. And it goes on to say that this policy must ensure the highest possible health status for Indians and urban Indians, and then provide all necessary resources to effect that policy. So specifically, it is the Indian Health Service, which is actually set apart through law, that receives funds and provides health services to Native Americans. So they're the primary agency responsible for rendering health care to American Indians and Alaska Natives. Next slide, please. So here we are looking at kind of the profile of the Indian Health Service. And just to give you an idea of where they serve and what they do, currently the Indian Health Service includes 12 areas across the nation. And IHS's, I say IHS for short, their 2020 figures indicate that 2.6 million members of federally recognized tribes are served. I'd like to point out that originally, federal Indian Health Service employees was the group providing health care, and it was mostly primary care directly to our Native population. So it was really the federal employees who rendered healthcare services. But today, tribes and urban Indian organizations may also provide services directly to Native Americans. So since the Indian Health Service has been around, some gains have truly been made in health status. But our tribal people do continue to suffer from chronic illnesses and really death at a higher rate than other populations. And so this is really important to note. Our Native population also has the highest uninsured rate as compared to other populations. And so I want to kind of circle back to the original point regarding trust responsibility, which is a major reason that this uninsured rate is so high is because tribal members expect the federal government to make good on this prepaid promise to render appropriate health care. So that's just a really important point as we discuss this topic today. So we have an expectation, and it seems clear cut, right? So we're going back on this premise that that this healthcare is a legal obligation, and the problem is that access to services isn't as straightforward. So we have clear cut expectations, but the actual access is not as easy as it should be. And so that kind of brings me to our next point, and this is just absolutely critical. It's critical for the foundation of our discussion today. IHS, the Indian Health Service, is grossly underfunded. So next slide, please. We'll kind of delve into that. And back up one, I'm sorry. There we go. Okay, so thank you. Not everyone knows that the Indian Health Service is chronically underfunded. And there are probably some misconceptions that IHS can and does meet all tribal healthcare needs. But the reality is that this agency is funded through a discretionary budget, and it's therefore dependent on annual appropriations by Congress. So this makes the Indian Health Service programming subject to budgetary constraints, and that includes rescissions and sequestration. So that really sets us back as our population is growing. So the agency is I would say, subject to the whims of congressional decision making, as many of us are. So their annual appropriations really are not stable, and that's an important point to make. It kind of underscores why we are where we are today. In fact, Congress recognized this situation, and as a result, Congress allows the Indian Health Service and tribes and urban Indian organizations to bill other federal programs and private insurance to supplement the funding appropriated to IHS. And I just want to briefly highlight how underfunded IHS is. And it's really easiest to express this in kind of a per capita funding comparison. So next slide, please. Okay, so when we compare IHS, so it's the last smallest bar on this graph, when we compare per user spending to other federal programs in this graph, and even the national health expenditure rate here, the Indian Health Service is funded at half or even less than that of other healthcare spending categories. So Here we have, we're showing that that it's funded at $4,000 per user. And an example by comparison would be the Veterans Affairs Agency. Their spending is more than double that in a per capita comparison. So one thing that's also interesting is that nationwide, we're talking this $4,000 per user is a nationwide per capita amount. But it's also important to note that funding is not evenly distributed across the 12 areas, and that complicates matters in access to care. Next slide, please. So this is kind of illustrated here in Oklahoma, and we'll first start with the Oklahoma City area because it's the largest in terms of user population or who it serves of all the 12 areas. And the funding, as it stands, this is a recent figure, is at $2,300 per user, which is much less than the $4,000 per user that we just discussed. So within Oklahoma, and the Oklahoma City area actually spans now 4 states, but what we want to do is kind of hone in on Oklahoma because that's what we're talking about today, and talk about how we work and where we're at in terms of funding. And sadly, within our own state, there are some health systems that are currently funded even less than the area average, and maybe anywhere from $1,000 to $1,500 per user. And that's a major problem. And it's a problem because without appropriate funding, we're kind of forced to ration care. And that's one way that the federal government really has fallen short of fulfilling its trust responsibility. So in addition to the funding problem, you'll notice the types of facilities. They're kind of scattered throughout this map of Oklahoma. And as a reminder, I barely mentioned this, but Native healthcare is administered one of 3 ways today, and that is directly by the federal government through IHS, by tribal programs, or through urban Indian organizations. And what's really noteworthy is that regardless of how programs are administered, most of our healthcare, and you can kind of see by looking at all the blue dots on this slide, most of our healthcare is basically limited to primary care. And that said, our health systems, especially here in Oklahoma, I have to brag, we've done a really great job of providing primary care. We're getting pretty good at it. And it's really something to be proud of. And even collectively, some of our patients, probably across the state, prefer to visit our health systems because they really do receive top-notch care in terms of primary care. I guess the problem is just that our ability to provide or fund even secondary or tertiary specialty care is very limited. And that makes it difficult, if not impossible, I would say, to treat chronic illnesses like diabetes, cancer, or cardiovascular disease. So if you remember, kind of one of our earlier slides listed some of our chronic conditions and health disparities. And that's one major reason our Indian health disparities and higher death rates do exist today, is because our access to care isn't comprehensive, and it's not even across the board either. It's just, this is a critical point as we begin to understand why Medicaid expansion is really so beneficial to our uninsured eligible population. We really hope that that population will gain access to specialty care. So now I'm going to pass it over to Robyn, who will highlight our urban Indian organizations and talk a little bit more about the access to care issues.
Thank you, Kasie, and thank you all for joining in this evening. It's my pleasure to talk about the Urban Indian Organizations, and I might say UIOs. For those of you out there that may not be familiar with some acronyms, but Kasie gave you a very high-level overview of the Indian health system. So we look at it kind of as an umbrella, and I've also heard it compared to a three-legged stool, in that we are all a leg of that stool holding each other up to provide health services to our American Indian, Alaska Native patients. So again, Indian health system, Kasie gave you an overview of the Indian Health Service. She and Yvonne are from tribal run programs, and then I am from an urban Indian organization. So again, we're all under this one umbrella, and our goal is to provide services to the American Indian Alaska Natives, and specifically tonight we're talking about those in Oklahoma. Next slide, please. So what is an urban Indian? So basically, we define that as an American Indian or Alaska Native who lives off reservation land and lives in an urban setting. So the last time, in the last census count, which in 2010, we've not analyzed the most recent data that's been out, but approximately nearly 80% of American Indians or Alaska Natives live off reservation. So are then, like you see in quotes, categorized as an urban Indian. And so what leads American Indians to leave off reservation? Many of them will leave on kind of short-term basis if they are going to get a higher education. There may be job opportunities. They might follow other family members off reservation. And so then they become an urban Indian. Next slide, please. So the urban Indian organizations, there are 42 nationally, and I'll show you a map of where they are. What makes us a little bit different than the Indian Health Service or a tribal program is that some of us are federally qualified health centers. So some of you are very familiar with community health centers. We're very similar to that. We are nonprofits. So we are nonprofit organizations in the state of Oklahoma. When I say we, I'm talking about Oklahoma City Indian Clinic, and then there's an urban clinic in Tulsa, Indian Healthcare Resource Center of Tulsa. And there are 42 nationally. Some of the smaller programs just run what we call drug and alcohol programs. So they are specifically treating dependency and drug and alcohol related conditions. Then you have some other programs that are smaller. They might have maybe one mid-level provider, maybe like a PA or a nurse practitioner, and maybe a couple of nurses. And basically what they are there to do is assess a situation, and then they have partners out in the agency, other family medicine doctors or dentists, behavioral health specialists that they partner with, and then they make a referral for that Indian patient to go there. And then there are others that are full ambulatory clinics like the Oklahoma City Indian Clinic and Tulsa. And we say full ambulatory. Basically, when I talk about our clinics, we provide full array of services except inpatient care. So, and then we're ambulatory, meaning our patients are most of the time are well enough to walk in, and then they're well enough to walk out. Next slide, please. So I talked to you about where the in UIOs, the Urban Indian Organizations, exist. There are 42, and you will see that most of the programs are located in areas where there are a lot or more populous with American Indians and Alaska Natives. The two largest programs are here in the state with Tulsa and Oklahoma City. And then a lot out on the West Coast are those programs that I mentioned about being outreach and referral. But today we're going to focus on our clinics here in Tulsa and Oklahoma City. But this gives you a good picture of where the urban Indian organizations exist. Next slide, please. So most of us, like I said, are primary care, meaning that we have family medicine doctors, dentists, we have behavioral health specialists. Many of us focus on the preventative side of care, knowing that we're trying to defeat chronic disease later on. So you will see a lot of community programs. You'll see public health programs with nurses going out into the community, immunization programs. Those are all part of the Indian Health Service model. And again, under that umbrella, the tribal programs and the urban Indian organizations. So what happens to our patients that come in and we're not able to provide services in our four walls? So for instance, if a patient were to come to my clinic and they were assessed, and let's say they were having chest pain and we needed to refer them to, let's say, a cardiologist. Well, we don't have cardiology in our outpatient primary medical center. So then what happens is, most of the time, unfortunately, Kasie mentioned the number of uninsured in our population. Well, then we have to go through what's called purchase and referred care. Purchase and referred care is a program that is either administered by the Indian Health Service or it's administered by a tribal run program. UIOs, urban Indian organizations, do not have PRC programs. So basically what happens is then our workers, our doctors, nurses will generate a referral and then send it to the PRC program. Depending on where that patient lives, we may have to contact a tribal program or we'll have to contact the Indian Health Service. The thing is, like Kasie mentioned, oftentimes it's considered ration care because the only thing that there are buckets of money for in purchase and referred care, because it's incredibly underfunded, is in life or limb situations. And so our doctors and nurses or whomever is generating those referrals know that a lot of times, many times, those referrals are not going to get paid for because they may not be life or limb. However, again, something like cardiology is incredibly important, but it may not meet that tier at that time, depending on the funding level. So these are all just kind of things that we have to think about when we are thinking about, again, rationing care, unfortunately, but again, trying to provide the very best healthcare that we can to our patient base. Next slide, please. So we know that there are around 40,000 American Indians and Alaska Natives that are currently eligible when Medicaid expands July 1. So the good news is that what we'll be able to do then is fill in the gap. So get as many patients as we can signed up for Medicaid expansion so that when I'm talking about those gaps that we can't fill in our four walls, that we'll be able to provide our patients with those specialty services that are beyond our scope of care and be able to provide them with the care that they need. And so that is why we have everybody under that umbrella that I talked about on the federal side, the Indian Health Service side, the tribal programs, and the urban Indian organizations have long advocated for Medicaid expansion, knowing that it will help us fill in the gaps. So basically what we're anticipating and what we believe the benefits will be to our patient base is that if there's medications that we currently don't have on our formulary, that our patients will have access to that. For that specialty care that we don't have under our four walls and we can't provide, that they'll have access to, again, those specialists. So hoping to, again, be able to provide that comprehensive care to keep our patients well. So at this time, I would like to turn it over to my colleague, Yvonne.
Thank you, Robyn. It's a pleasure to be here tonight, and I have the distinction of wrapping this up and talking about Medicaid expansion, something that all of us have been extremely excited about. So the good news is July 1st, Medicaid expansion comes to Oklahoma. It's about time. And again, we're anticipating about 200,000 Oklahomans will gain eligibility under this expansion. So who is the expansion group? Well, the expansion group is the adult population 19 to 64. Next slide. With household incomes at or below 138% of the federal poverty level, and I'll show you a graph in just a moment. They have citizenship, and they are residents of Oklahoma. And if they are parents of minor children, they must cooperate with child support services if their children are enrolled in Sooner Care at this time. Now, one of the special provisions for the American Indians and Alaska Natives is they are not required to cooperate with child support services. So that's something I always like to make sure that we educate our members on, that while they're welcome to cooperate if they want to, they are not required. And Healthcare Authority has actually fixed their enrollment system so that when you mark that you're a member of a federally recognized tribe, that it won't even ask you to cooperate with child support services. Next slide. So here is the graph that I promised you, and you might want to blow that up, yes. So at household of one, you have a single adult, and if their income is less than $17,796, $17,800, then they're now going to be eligible to enroll in Sooner Care. A household of three, you're looking at approximately $30,000, $30,312. And these numbers are close. If they're a little bit over, I would still recommend people apply. But this is what represents 138% of the federal poverty level. And so if you see yourself in this category, make sure you sign up. If you know a neighbor and you think they follow, make sure we share. Let's get as many people enrolled as possible. Next slide. Okay, so enrollment is I said it will become effective on July 1st, and the Healthcare Authority has agreed to open enrollment 30 days in advance of the effective date. So the good news about this is that Oklahoma Healthcare Authority has an outstanding enrollment system that allows real-time eligibility, enrollment and eligibility. So if you apply online, and you submit your application, and when it processes and you meet eligibility criteria, you will be immediately effective on the date of your application. Now, if you're applying in June for Sooner Care and you're part of the expansion group, it will give you eligibility on July 1st. But, what we're finding is a lot of people are going out and checking eligibility and find out they're already eligible and they just didn't enroll. So the day you process that application, you have real-time eligibility. And your only delay is if you're in the new expansion population, and you'll only have to wait till July 1. Next slide. So how do I apply? Well, there's several ways. Again, mysoonercare.org is the online application where you can go, and an individual can complete their application in the comfort of their home. They can do it at the library. If you want to go in, anybody that has access to the internet, if you go on there, you can just step through enrollment process, and it's very intuitive, and you can get your application done right there. Or if you don't have access to the internet, you can call by phone to the Sooner Care helpline, and I've provided the 800 number on the slide. You can visit any Indian Health Service, tribal, or urban Indian organization clinic, and they can assist you to complete your application either in person or by phone. So you don't have to be front and center. If you call them, they can help you over the phone. So again, we feel like it's very easy to get there, and we're standing ready to help you. Patient benefit coordinators are awesome individuals working in the ITUs, and there's nothing that makes them happier than getting people enrolled. Now, if you don't have access there, Steve Goldman is the navigator for Oklahoma, and he does an outstanding job getting people enrolled into Sooner Care, Sooner Plan. And if you're not eligible there, Steve gets you enrolled in the marketplace. And that's something the tribes can help with as well, but Steve does an outstanding job. And Steve's email address is here. You can reach out to Steve if you have any questions. He also has given us his phone number that you can either call him or text him. So another great resources. There are a number of nonprofit clinics, federally qualified health centers around the state, and there'll be other other places you can apply as well, agency partners and DHS offices. But right now, we're really talking about tribal. And so oftentimes individuals enjoy coming and working with their tribal clinics, and we encourage that. But there are resources, and we're glad for you to reach out, and we will help you with that. Next slide. Outreach and enrollment. While we are extremely grateful that Healthcare Authority made the decision to open up enrollment for June 1 instead of the July 1st date that they had originally planned, there's still a need for a coordinated outreach and education effort. And we feel like that includes newspaper articles, flyers, posters, brochures, social media. How do we get the information out to those that are eligible so we can get them enrolled and they have this access before it's needed? And as you heard from tonight's presentation from Kasie and Robyn, we've got a population that has not been able to access a lot of the specialty care that they may have needed to improve a quality of life that ultimately leads to better health down the road. So we're extremely excited about this, and we really want to get the word out so that everybody takes advantage of this. Our ITUs are actively working on preparing an outreach and activities to assure that our population is aware who qualifies, where they can enroll, and when they can have active coverage on July 1st. Next. So one of the ways to streamline this enrollment is the Healthcare Authority is going to reprocess some existing benefit categories, and they will automatically enroll them for July 1. So they estimate approximately 100,000 individuals with current eligibility in the following benefit categories will automatically enroll for July 1 without taking any action. So that is great news. That's half of the population that's expected to be eligible. So we want that to be successful. So what are these benefit categories? If you or someone is enrolled in the Sooner Plan eligibility, that's family planning, then if you're active between May and June, they are automatically going to process your app and move you into full Sooner Care July 1. The same is true with Insure Oklahoma individual plan and the Insure Oklahoma employer-sponsored plan with individuals with incomes at or below 138% of federal poverty. Now, that program will still exist for those that are above 138, but for those at 138 and below, they are going to transition right over into Sooner Care. Now, parents of minor children who have current Sooner Care eligibility, this is a conditional. If they have updated their application between April 1st and June 30th, and they're going to cooperate with Child Support Services if they're non-native, then they will automatically be enrolled for the July 1st effective date. However, if they did their application last December, which they get a year's worth of eligibility, and they haven't updated their app, they will not automatically be enrolled. So this is definitely a target group that we want to make sure that they know we need to get their application updated, or they need to update their application so that they just roll smoothly into Sooner Care on July 1. Next slide, please. So what are some resources? Well, not everybody hovers the Healthcare Authority website like a few of us policy nerds do, but it is a wealth of information. So you can go to the Healthcare Authority website, which is just www.ok.hca.org. There you can look over to individual eligibility, and under that category, you can see the mysoonercare.org link, where if you want to do it yourself, there's also a guide that gives you step-by-step instructions on how to complete your application. It also outlines the different benefit categories that you might be eligible for. Again, a wealth of information there. Now, if you're interested in seeing what the Healthcare Authority has on its website regarding Medicaid expansion, you look over to the right at the OKHCA.org website, and you will see a Medicaid expansion, or you can click on the link that I've listed, and it will talk to you about who and who's included in Medicaid expansion, give you examples. There's a lot of good information there. Again, tonight we are talking about Medicaid expansion, but if you're listening to anything these days, if you say Medicaid expansion, right behind it is Medicaid managed care. And so the governor would like to move the population into an outsourced privatized managed care organization on October 1st. And everything is underway to make that enrollment happen. So if you'd like to take a look at what is going to be Sooner Select, the managed care program, that link is out there as well. So they awarded a 4 health managed care organizations award and 3 dental health managed care organizations that will come into play on October 1st. And again, there'll be opportunities to enroll. But the critical piece, and why I'm mentioning managed care, is that I want you to note that American Indians and Alaska Natives are not required to enroll in the managed care plan. They can stay right with their tribes. They can be with ITUs, and they don't have to skip a beat. There's nothing they have to do. We can continue to handle everything for them. Now, if they want to join a managed care plan, they can opt in, and that's certainly their choice. So, but that's the tidbit I want to leave you with. The last resource that I want to mention is that the Healthcare Authority has bi-monthly tribal consultations. And again, there is leadership and policy staff, tribal policy staff across the state and the nation. And in Oklahoma, it's always been a pleasure when we meet at a national level to talk about what a great tribal consultation policy the Healthcare Authority has. And so we meet bi-monthly. Their director's name is Dana Miller, and she's Director of Tribal Government Relations. So behind all the things we've been able to accomplish as advocates for the tribes, there's a host of tribal policy staff that are out there and making this happen, in tribal leadership. But we do want to give kudos and recognition to our partners at the Healthcare Authority, and just make sure you know what all we reach out and touch in knowing about Medicaid expansion. Next slide. So let's make this a success. Everyone deserves access to care. In the days when I would go out and train the county health department staffs across the state, something I love my public health workers. And I found a home with tribals as well, because public health is alive and well there. I used to start my training and say, who is eligible for Medicaid? And you'd see everybody kind of looking around, and every now and then you'd see a hand go up. And what I would say is basically, potentially everyone is eligible for Medicaid. All it takes is a life event, and your world can change. And thank goodness we have Sooner Care, or Medicaid expansion, or Medicaid services available to us in this expanded population, so that we can access the health care we need to improve the health of Oklahomans. And this will also bring a huge economic impact that will benefit our Oklahoma hospitals, our providers, and create more jobs for Oklahoma. Thank you for letting me speak to you tonight, and I'll turn it back over to Emma.
Awesome. Thank you so much to all of our speakers. We have a few minutes for questions, if there are any. Okay, yes, I see one. Okay, this sounds like a question for me. If you have other questions for our speakers, feel free to throw those in the chat as well. The question is, given where the state is now in the rollout process, what one specific action item is Oklahoma Policy Institute advocating this evening? So I know you asked for one, I'm going to say two. We first really want to applaud the Healthcare Authority for opening that early enrollment period, but we also want to push for a comprehensive outreach plan. If you think back to the before times, before COVID, when you were trying to get the message out to a group of people, whenever you were trying to, say, plan a party, you would call people, you would text people, you'd make a Facebook event, you would use all the avenues available to you to get that word out. And we want the Healthcare Authority to do the same thing here. We want everyone who's eligible to know that they're eligible, and to know how and when and where to apply. That's really the only way we're going to get the full benefit, the full economic and the full health benefit, is if everyone who's eligible knows and is able to apply. And then the second thing is to fully fund Medicaid expansion. We are maybe 2/3 of the way through session, and in the next few weeks we'll see the budget, and it's really important that Medicaid expansion is fully funded again, so we can get those economic and health benefits. All right, so we've got another question. This one is for Robyn. The question is, will people still be able to access care through ITU facilities once they are enrolled in Medicaid?
Definitely yes. So we are going to do everything we can to get as many of our patient base enrolled that are eligible. So out of the 40,000 that we talked about, everybody that comes into one of our facilities will be screened. And so hopefully we will be able to get as many enrolled in Medicaid expansions. So definitely yes.
Awesome, thank you. All right, we've got a question for Yvonne. Since Oklahoma's enrollment system allows real-time enrollment, does that mean people can start using their coverage the day they are approved? Can they go to the doctor that very first day?
My normal answer is yes, because once eligibility is determined, the only exception is if you're enrolling in June and you're part of the expansion group that will be effective for July 1, then you're going to need to wait. But of course, if you're a tribal member, you can continue to access the services that you have right now, but get enrolled. And but for people, a lot of times I mentioned, let's say somebody's coming in for their well visit and needs family planning. If they get their application completed today and they have their visit today, then they're effective today. They'll receive all of their services when they go into either a tribal or an IHS clinic or urban clinic. And then that clinic will be able to bill Medicaid for the services they receive. So not only did the client receive the services they need, the tribe was able to bill and get that revenue to come back in to help shore up that grossly underfunded tribal sin.
Awesome, thank you. Okay, another question for Yvonne. If I don't fit into one of the groups that will be automatically enrolled, when should I apply for coverage? You just alluded to this, but we can just reiterate it.
Absolutely. You can't tell I'm excited about this. Officially, the doors open on June the 1st, if you don't fit into one of those policies. But what I would say is that you're going to most people are going to be eligible to enroll in Sooner Plan. So if you're someone that needs family planning services, I would complete an application anytime now, and I would apply for Sooner Care and I would apply for Sooner Plan. You're going to get your eligibility with Sooner Plan. You'll be denied, but either way, those two requests are going to put you in the auto enrollment group. So let's don't miss out.
Absolutely. All right, thank you. The last question is for Kasie. Well, potentially the last question is for Kasie, and that is, besides advocating for a fully funded and accessible Medicaid expansion, what can advocates do to help improve access to care through ITU facilities?
That's a really good question, and I'm glad that it was asked. I think one of the biggest things that can be done is advocacy. In terms of advocacy, is reach out to your congressional leaders, and that's at the federal level. So our U.S. representatives and senators, because they have an idea that we're underfunded. They hear that from us every year, but I think it's really meaningful when their constituents who aren't kind of in the weeds with tribal policy, health policy, and advocacy. I think when they hear it from patients at the clinic or tribal families, I think that's very meaningful. And we have a couple of congressional members who are tribal members themselves. So I think that's one of the most impactful things that you can really do outside of what we discussed today in terms of access to care.
Awesome. Thank you so much, Kasie. I think that is our last question. So I just want to say thank you so much to our speakers for taking the time to do this. I learned something every time I listen to you all, and I hope that our audience did as well. We will have more events coming up to count down to care, count down the 2 months until Oklahomans get the health care that they need. But in the meantime, you can help ensure that expansion implementation is done well by visiting okpolicy.org/countdown to take action. From this page, you can call and email your legislators to tell them that you want Medicaid expansion to be implemented effectively and fully funded. You can also share your Medicaid or healthcare story so that people truly understand what's at stake here. You can also find our upcoming events at that same page, okpolicy.org/countdown, or on our social media pages. So keep an eye on that, and thank you so much to all of you for listening, and have a great day.